thank the organizers of the committee for this conference, for giving me this opportunity. So let's move ahead. Right now, the topic of this debate is pathogenesis of type 2 diabetes. Yes, it is important what happens to us before we become diabetic, but that was primarily what Dr. Neeta was talking about, which was completely different from the topic given to us. So let's see what actually happens in patients with diabetes. I'm not even talking about insulin resistance because it's really obvious that beta cell failure is the dominant pathophysiology. So this is when we were friends, we've had good times, and post this debate, she's probably going to kick me out of the room because we have the same room incidentally. And that also happens to be my conflict of interest. I need to save my room today. Now look at ADA and what they have said in the classification of diabetes. Okay, so type 2 diabetes, there's a progressive insulin secretory defect on the background of insulin resistance. They themselves have called insulin resistance. They've used the term background, so it's obvious right there that beta cell function is the primary defect. Now, if a person does not have beta cell dysfunction, no matter how severe the insulin resistance is, he is never going to develop diabetes. Beta cell dysfunction causes diabetes. Insulin resistance, no matter how profound it is, in isolation can never cause diabetes. So yes, we have several different pathophysiological mechanisms involved. We will not go into all of that. We look at beta cell function today. So we have a lot of evidence from a number of studies which have shown that as a person moves from normal glucose tolerance to IGT to type 2 diabetes, the beta cell function keeps dropping. So when you have type 2 diabetes, at diagnosis, most of your beta cells are gone. Go back a bit, when you have IGT, about 80% of your beta cells are gone. Forget about that. Look at normal glucose tolerance. Look at the difference between a lean individual and an obese individual. All of you are thinking, yes, obesity needs insulin resistance. I'll show you in the next couple of slides how obesity can cause a disruption in your beta cell function. This happens to just be the first of those slides. So beta cell function is not a late change in diabetes. A person who has diabetes already has advanced beta cell failure. We already know this. And I will not repeat this slide because this has been discussed by the previous speaker. So we have another set of studies where patients with type 2 diabetes have been studied. And if you look at, sorry, this is not working. Yes, so if you look at insulin sensitivity, it more or less remains the same, the insulin resistance, and the beta cell function declines. It does not mean that there's nothing you can do to save the beta cell. Yes, you can, and let us see what we can do to save these patients, save these beta cells. So yes, both these pathophysiological processes are involved. It is difficult to isolate in a clinical setup which is more dominant, though I will tell you that beta cell failure is more important. But all of these, both these physiological mechanisms, pathophysiological mechanisms, cause metabolic derangements. It causes glucotoxicity, it causes lipotoxicity. So what does this cause? This in turn again causes worsening of beta cell function. So insulin resistance also contributes to beta cell function. And along with that, what happens, even your diet, what Dr. Neeta was saying, increase in fatty acids, obesity, all of that directly has an effect also on the beta cell function. It is not just on insulin resistance. So what happens in younger people? Because we have a larger instance of people in second and third decade coming with pre-diabetes and diabetes today. So if you look at this data, if you look at patients with NGT, IGT and both IFG and IGT, and if you look at the insulin secretion, you can see that those who have normal glucose tolerance, the insulin secretion is normal. But as they progress to pre-diabetes, the insulin secretion drops. So insulin secretion is affected, beta cell function is affected even before a patient develops diabetes. It is not just at the onset of diabetes or much later in the course of diabetes. So this is a slide that tells you the importance of normal glucose tolerance. So we had in the previous slide different categories. When these patients with NGT were followed up, some of them developed diabetes later, some of them did not. And even in these patients with NGT, those who developed diabetes were those who had a lower beta cell function in the beginning. So people with normal glucose tolerance may have a lower beta cell function in the beginning and they can progress to form diabetes, progress to develop diabetes compared to people with NGT with a slightly higher beta cell function. So beta cell function is clearly very, very dominant in the pathophysiology of prediabetes and diabetes. What about adipose tissue? So we talk about subcutaneous fat, abdominal obesity, and we talk about visceral fat. So if you look at this data, this is in the same study, so when these patients were followed up, all the people who had more of visceral fat around the liver, which was measured with MRI scans, they had lower beta cell function. Yes, they also had lower insulin sensitivity, but it does not mean that obesity, losing weight, is the only way to reduce insulin resistance. How do you know that you're only reducing insulin resistance? You're also improving the beta cell function in each and every of these patients who reduce weight. So this was a study which proved exactly that. So they had patients with a BMI of 35 and patients with, they were put on lifestyle measures along with treatment. They lost weight, and if you look at this curve on top, from 35 BMI to 30, you can see that beta cell function drastically improved. So when we say that measuring beta cell function, knowing beta cell function is not important, I completely disagree. Weight loss is important. You're never going to stop implementing lifestyle. You're never going to stop using metformin. But don't think that it only causes decrease in resistance. It also improves your beta cell function. And this has also been studied in India. It is not just the Caucasian population. So patients, when they were studied from NGT, IMG to diabetes, there were differences in the insulin resistance. There was increase in insulin resistance as they moved up from NGT to diabetes, and there was also a decrease in beta cell function, that is the disposition index, as they moved up this ladder. But the differences in the beta cell function were more significant statistically. This was even in patients at a lower BMI, because we know that Indians have a lower BMI compared to the West. So to recap, beta cell function is predominant. It begins early. It is always there. It happens even in patients with normal glucose tolerance, in people with normal glucose tolerance. It is seen even in the youth, not just in adults. So yes, both these concepts are present, both these mechanisms are there in every single individual. So what are we going to do with this in our practice? So this is important because we need to target pathophysiology. Treating diabetes is not just concentrating on glucose lowering. Treat the pathophysiology. Start therapy early. Start multiple drugs. This is the only thing that achieves durable reduction in HbA1c. This is the only way to save the beta cell. And this is the only way to slow down the beta cell failure. Insulin resistance more or less is going to remain constant. Implementing weight loss, using pioglitazone, all these are going to save your beta cell. Don't follow the treat to fail algorithm where you start one drug, you wait for a response, you fail, and then you start the next drug. So this at some point is going to make each and every patient of yours lose a lot of time, and in that time they could be losing more and more beta cells. So implications, know what drugs you're using and how these drugs act. So how do we save the beta cells? We have several drugs. I'm not questioning the use of metformin. Metformin is used in all patients. Sulfonylureas, they improve insulin secretion, but they do exhaust the beta cell at some point of time. DPP-4s, yes, the durable effect on A1C lasts for only a couple of years, but at least there's no exhaustion on the beta cell. GLP-1 analogs, they also improve beta cell function to a larger extent than DPP-4. And we also use insulin right early at the diagnosis of diabetes in order to save the beta cell. So we actually had a discussion over lunch. Dr. Neeta, Dr. Michael Hermes and I were sitting and discussing, and he was telling us that he calculates insulin resistance and beta cell function in each and every one of his patients in clinical practice, not research. Those who have a lower beta cell function, he starts them on insulin early, he follows them up more frequently. So this is something that we also probably need to sit and practice. And this is what I'm implying. Beta cell function is important. When they follow it there, we obviously need to follow it and save our beta cells here. Never forget pioglitazone. Pioglitazone is a fantastic drug. It reduces insulin resistance, improves insulin sensitivity, but studies in animals and in humans have shown that it not only produces a durable A1C reduction, it preserves the beta cells. They have found an increase in islet cell mass in rat models, and in humans they have shown that there is an improvement in the disposition index. So using weight loss, using pioglitazone is saving your beta cells. We all know the triple therapy that Diffronzo has proposed. So this acts on multiple pathways. So I'm not saying don't target your resistance, it's important, but you need to target your beta cells as well. Save your beta cells. We have very few of them left. It's obviously important. That is what carries you on for the rest of your life. So what side are you on? I hope you choose to save the beta cell. That's the right thing to do. We have very few of it left. Thank you.